Good afternoon, and welcome to our Impact Seminar on Health Equity. I'm Ann Hoyt, a retired University of Wisconsin professor, previous board chair of NCBA, and board chair now of the Group Health Cooperative of South Central Wisconsin. With me today are Dr. Mark Huth, a family medicine doctor, accomplished pianist, organist, and choir director, and the president and CEO of Group Health. And also with me is Carrie Odell, a graduate of the UW-Whitewater University with a business administration degree in human relations management, wide experience in human resources, and chief human relations officer at Group Health Cooperative. Group Health is a obviously cooperative business. Next slide, please. We are a member-owned cooperative in Dane County, which encompasses Madison, Wisconsin. We have 76,000 plus members, 800 and more staff, and we're a staff model HMO. By staff model, that means that our doctors are paid on salary rather on fee for service, which keeps our costs down. And we offer both insurance and a complete medical delivery system. Perennially, we are recognized in the top 10 of healthcare providers for quality and service. And we have been twice recognized as the top plan in the United States, a real feather in the cap of cooperatives. And we are, as a board, governed by an 11-member board. 11 of our directors are elected by our members. 9 of our directors are elected and 2 of our members are appointed by the board. Today, we'll be hearing from Mark and Carrie. Mark is going to speak on our co-op's leadership commitment to health equity and healthcare delivery. And Carrie is going to be speaking on our diversity, equity, and inclusion framework for us as an employer. Following their presentations, we'll go to a question and answer period. Next. It's important that we know what we're talking about when we talk about health equity, so I thought I'd give a little introduction and take these from various organizations. So according to the Institute for Healthcare Improvement, health equity is achieved when every individual has a fair opportunity to achieve their full health potential. However, that is difficult because there are some factors outside of any individual's control that create health disparities. And the health disparities are differences in health and access to healthcare across different groups. For example, income is very important, and people in low income groups have more obesity than those in higher income groups. Race and ethnicity are important. You may have already heard about this. Black and African Americans, American Indians, and Hispanic groups are more likely to die of diabetes than whites and Asian Pacific Islanders. Geography is also critically important. Medical conditions such as heart disease, cancer, and diabetes are more common in rural areas than in urban areas. And then finally, I'm sure you all have heard the news often and more often that COVID-19 mortality rates are more than twice as high in Black, Latinx, and Indigenous populations than in white populations. These and other disparities are, according to the Robert Wood Johnson Foundation, avoidable, unfair, or remedial differences in health outcomes. But we have discovered, and I'm sure you've heard this as well, removing these obstacles to health equity isn't easy. They include poverty and discrimination, powerlessness, lack of good jobs with fair play, quality education and housing, safe environments, and access to quality healthcare. That's from the World Health Organization. In our interest in increasing health equity, it's clear that addressing these issues is in many cases beyond what we can do in healthcare. Next, please. And now I turn the meeting over to Dr. Huth, who will talk about what we're doing as an organization to increase health equity. Dr. Huth?
Thank you, Ann, and good afternoon, everybody. It's great to be with you, albeit virtually, and looking forward to the conversation today. Carrie and I, as Ann said, will go through a few slides and talk about our experiences, not just with health equity, but also the larger topics of diversity, equity, and inclusion. And want to just kind of present our journey and our observations, knowing that we are early on in what will be a lifelong process of striving for health equity and diversity, equity, and inclusion, both as an employer and as a healthcare organization. So I'll just share a few observations and then also our experiences over the past few years. Many of you have probably seen this cartoon or this diagram that is meant to show the difference between equality and equity. On the left, everybody has a crate to stand on, but obviously because of the heights of the individuals, not everybody is having the same experience. And equity is where everybody has an equal opportunity. And we use this diagram quite a bit early on, but you know, we are learning every day about this, and we became aware of the fact that there is unfortunately a bit of a subliminal message here in this, in that the individual there in the purple shirt has more needs, or is more needy, or is not as capable as the other two people in the diagram. And that's not really correct when you think about equity. I actually like this diagram a lot better. And if you notice what's happened here, everybody is the same height. Everyone has the same capabilities and the same skills. It's just that the ground is slanted beneath the feet of the person in red and yellow. And then also the fence is higher for some than for others. And I think this is a better message to send. Everyone in this diagram is capable, but equality is not really achieved when the foundation that people are sitting on is more challenging, or the obstacles that people face are greater. And so achieving equity actually means giving a better foundation, better resources to people that don't have it, and then overcoming the obstacles that people face, which if you're not in the minority or you're not in those groups, it may be very, very difficult for you to see. So health equity has to be a strategic priority. We have been on this path for quite a few years, and as I said, we have so much more work ahead of us. In 2017 and 2018, we developed a new strategic plan, and one of our driving strategies is very much speaking about health equity, and in that we are called to enhance access and equity for our services, and that we want to continue health equity efforts and actually expand them. And Carrie will talk about another place in our strategic plan where we talk about diversity, equity, and inclusion. So we formed a few years ago a health equity committee with 1 to 2 representatives from a variety of departments across the organization. It's a very diverse group. It's very large. It's about 25 to 30 members. They meet during the workday, so we are dedicating time and resources to them. They don't have to come in early or meet in the evenings or weekends. And their focus is very much on health equity and patient care. So how are we doing as a healthcare provider and insurance provider in serving all of our communities equally? And this obviously is a huge issue. It's one that has become more well known, but there's a lot of work yet to be done. So this group helps us to recognize the disparities and discrimination that are just part of the structure of healthcare, including a group health cooperative. And then they are charged with helping make changes within the organization so that we can be more equitable and more successful in serving all of our patients. One of the things that they did early on is they established some very, very strong statements about who we are as a healthcare organization and what we believe is true if you are being equitable with your care. And so these outward facing statements were developed by the Health Equity Committee, and they are present throughout our facilities. And we made sure that we had them translated into the 6 most common languages that we see in our clinic delivery system. So the 4 statements, just very quickly, are: we believe that equity celebrates our humanity. We believe healthcare is a human right. We believe in treating all people with dignity and respect. And we believe there is strength in diversity. So these 4 statements are literally plastered on the wall in every single one of our buildings. They are a source of pride to staff that see them and understand what our stance as an employer is. And I think that they are also very reassuring to our patients who come in and see these. Now, the thing, though, that we have to be careful about is what we promise, we absolutely have to deliver. And so this is more than just a fancy decoration in our clinic. If we are promising that we believe these 4 concepts, then we need to make sure that our actions speak to that. Another group that we formed a number of years ago is our LGBTQ Health Committee. And their focus was on making GHC a place of welcome for everyone. And we have education for staff on using proper pronouns and greetings and questions and statements, because many times people who are something other than cisgendered or have a different gender identity, they will experience microaggressions just by the way that providers and nursing staff will talk to them about their health issues. And they have a specific desire as far as the pronouns that we use and the types of things that we ask, or how we refer to them in their relationships, their identity, their view of their bodies. And so we need to be very respectful of this. And so we've had a good education for this. We also are very careful to have in-depth training about the unique health issues and screening protocols for our non-cisgendered patients. And then we do have some providers, while all of our providers have some level of training in the care of non-cisgendered patients, we have a few providers who have it as a very strong area of interest. And so we highlight those providers so that patients who need these services can be connected with the correct providers. The other thing that we got through the LGBTQ Health Committee is changes to signs in clinic. And I'm sure you all remember that a few years ago, there was a lot of discussion in the news and a lot of reports about transgender individuals or non-cisgendered individuals feeling very unwelcome in public buildings and even being barred from restrooms. And so we, as I said, want to be a place of welcome for all people. And so we decided that we needed to change the signage in our clinics to portray or to present that, welcome to all of our patients. Some of the local groups simply put up very generic signs that say restroom. But LGBTQ Health Committee really advocated for us having these signs to say all gender. And this was meant to acknowledge the fact that we know that we are visited by people with different gender identities, and that they are welcome, and they're welcome to use our restrooms. And so that was a strong statement, and I was really proud for them to bring that forward. We also have signs throughout our clinics and admin building that go further to say you should be welcome to use the restroom that best fits your identity, and we do have single stall, all gender restrooms available to you if you wish. And so this is very proudly displayed throughout our clinics as well. These may seem like really small things, and for a lot of us, they may escape our notice. But for people who have a different gender identity, this is a very, very strong statement of acknowledgement and, as I said, welcome to them. So shifting gears, I want to tell just a very quick story about one of the most stark moments in our health equity journey. In 2018, the National Committee for Quality Assurance awarded Group Health 5 out of 5 stars for quality in healthcare. And that is their highest honor. We were very, very proud when we received that. And we were, at that time, we're only one of 2 health plans in the United States that had received that acknowledgement or that rating. And we had the best overall score. And effectively, that put us as the #1 health plan in the United States in the commercial space for quality. And we were very, very proud of that. And as you can imagine, there were a lot of individual results that were very good for us. We were #1 in child and maternal health and in plan satisfaction, #2 in respiratory, #3 in cardiac, #5 in preventative medicine, #10 in effectiveness of care. So we were feeling really, really wonderful about ourselves, and deservedly so. I think we were very, very happy and very proud of that. The other thing that we focus on is how well we serve our patient population. And are we a place of welcome? Do we treat people with compassion and empathy? Do we respect their privacy? Things like that. We have a lot of training and work internally to improve our scores in this place. And actually, if you look at the orange line at the top, in 2018, we are in the above the 80th percentile for the measure of would you recommend the office to other friends and family. So we were on cloud 9, and we were feeling really, really fantastic. We were #1 for quality. We're above the 80th percentile in this really, really important graphic or measure. But you probably know what's coming. A few months later, we received what are called the Badger Care Plus CAP scores, and this is our Medicaid CAP scores. The same year, we were the #1 health plan in the United States for quality. We ranked lowest in the state in our Medicaid population in 7 of these 12 areas. Getting needed care, getting care quickly, how well the doctors communicate, our customer service, our coordination of care, ease of filling out forms, and the overall rating of the health plan. And you can imagine what a shock this was to us. And it told us a couple of things. First of all, if we didn't believe that health equity was a thing and something we had to work on, we had very solid proof that it is an issue and that not everyone who comes to our clinic receives the same level of care. We knew that that was the case, but we didn't realize the disparity was quite so great. But what this also told us to do is to look at our data much more carefully and not only look at the aggregate because we had a great overall score, but to split things out and to really look at how we're doing with different patient populations. The other challenge that we have that is larger than group health is in Dane County, which is where Madison is located here in Wisconsin. It has been found in the last few years that babies born to Black mothers are twice as likely to have low birth weight compared to babies born to white mothers. And what's more, the infant mortality rate for babies is nearly 3 times the rate if they are born to Black mothers versus white mothers. These are the same physicians seeing these patients. These are the same hospitals seeing these patients. But very, very clearly, we have a huge gap in care. In fact, that gap for birth outcomes and for infant mortality rate is the largest disparity in the United States. And this was another stark reality that we have been facing over the last few years. And it's kind of that unspoken truth. It's easy to think that Madison is a wonderful place to live and very, very progressive and a very, very good community. And it is, but it isn't for everybody. And you really have to come face to face with the data. And then once you identify the problem, you have to work to fix it. The good news is the Dane County Health Council here in Madison, of which we are a member, has a very, very ambitious project to improve birth outcomes. And we're working with other community organizations and community leaders to reverse this trend and close that gap. So this is probably due to a multifactorial set of issues, but certainly the experience within healthcare has to be a factor in these birth outcomes. So when we were presented with these disparities and with our poor showing with our Medicaid population, our board and our leadership responded very, very quickly. The board actually revised their charter for the Quality, Safety, and Patient Experience Committee and expanded the health equity focus and wrote monitoring reports having to do with that so that we could routinely be measuring how we are doing in the health equity space. Our board also was one of a number of boards and organizations in our county that signed a 2018 resolution declaring that racism is a public health crisis. And then they went on a very ambitious learning program to expand their knowledge and their understanding of health equity. And that included health equity presentations and discussion at committees and the full board meetings. And it also included what Dr. Hoyt refers to as our book club. And one example of that is the entire senior leadership team and the entire board of directors read this excellent book called White Fragility and Why It's So Hard for White People to Talk About Racism. Robin DiAngelo is a wonderful writer. If you have not read this book, you need to read this book. It is a very, very insightful, very powerful read, and I think it was very eye-opening. So we all read that book, and then we had a health equity and implicit bias presentation. Oh, I'm sorry. What we did after reading this book is we had a workshop in an afternoon for both the board and the senior leadership team together to talk about what we had learned and talk about how health equity and how racism and other forms of discrimination are baked into the very structure of our organization as it is throughout society. Our leadership also responded in kind. We had a health equity and implicit bias presentation at our all-staff meeting. So we talked about these issues and we talked about what health equity and implicit bias really is and how we need to be better. We also established health equity as a foundational expectation for our leaders and actually every employee, but especially our leaders. And so leadership throughout our organization knows that we expect them to be doing the work in this realm. We're also actively working, as Carrie will talk about it later in the presentation, we're working on increasing the diversity, especially among the management within the organization, so that our workforce looks like our community. We did create a health equity leadership position that reports through HR and also has a dotted line relationship to me and to the board of directors as well. That position actually is currently vacant, but we are working to fill it. That person is very valued within the organization and in the past has brought tremendous knowledge and expertise to this, and they have really helped us along that in our journey. As I said, we, as a leadership team, we participated in that white fragility experience and workshop with the board. all of us on the senior leadership team also attended a 2-day deep diversity conference done by someone called Shaquille Chowdhury out of Toronto. This is something else I would recommend for everyone. It was a very, very powerful 2-day experience. It was something where it was very uncomfortable because the discussion really centered on how embedded discrimination and racism is in our society and in all forms of power throughout our society. But in addition to being very sobering and very depressing, it was also very inspiring because the other part of that is, now that you know about this issue, how can you change it? And how do you do specific things so that you can be a change agent in the world? And it was, again, a very, very wonderful experience, and I would deeply or highly recommend it. So I talked before about the problems with our data, where in the same year, 2018, that we were the top health plan in the United States. We also were last in 7 of 12 categories as rated by our Medicaid population. And so what we have done is applied our health equity lens to our data now. And we don't look at things only in aggregate, but we look at things by different views, so different socioeconomic class, different racial and ethnic groups, gender identity, sexual orientation, age, and socioeconomic status, as I said. And as you can imagine, we are finding that as good of an organization as we are in healthcare, we do have places where we need to be much, much better, and we are not providing the equitable care that people deserve. And so one of the other things that we did in the last year is our community care department is a department that works directly with our Badger Care Medicaid population and our underinsured or uninsured. They also work directly with local elementary schools, and they also house our interpretive services for our patient care as well. And they were pretty much a standalone department before, but what we did is we moved them into our population health and quality department because we wanted to bring subject matter experts together. And we wanted the people that were applying the health equity lens to our data to be able to work directly with people that were working with these populations who were not receiving equitable care so that we could have even better data, and we could make changes to our delivery system so that we could shorten or close that gap in health equity. One of the other things that we did just very quickly is within our health equity committee that I discussed before, we noticed that there were 25 people, and there was a lot of great discussion, a lot of great learning, and they were very much a force for change within our organization. But we took some steps ahead by establishing subcommittees within that group. And we'll have 3 or 4 people working on different subcommittees moving forward, depending on what their interest is or what needs to be done. And it's kind of the best of both worlds. We have the large group for the discussion and the learning and the education, and the larger kind of philosophy of health equity and how to improve. And then we have smaller work groups that may work with health literacy, for example. It has been widely reported that many people do not understand the language that we use on prescription bottles. And one study a few years ago found that a full 40% of patients were not taking medications correctly because they didn't understand what many people thought were very simple instructions, like take 2 tablets twice daily. And so we have a focus group working with health literacy right now, not specifically to improve the literacy of people coming in, but rather changing the way that we interact with people so that we use language which is understandable to them. So that has been a really great thing. And we have a facilities team subcommittee within health equity. We have a pharmacy committee. We have lots of different committees now that are charged with making changes. And so that has really supercharged those efforts. So that's a little bit about our path as a health equity provider, and be happy to answer questions at the end. It has been a long road so far, but as depicted in this picture, we have a lot of road ahead of us. And truly, this will be an effort that we have to do for the rest of our days. But it is very, very important. As Angela Davis said, you know, once you know that health equity disparities and gaps occur, you simply have to do that. It is your life's work. And so we have, I think, done a good job of identifying the gaps, and now the work that we have to do is to close those gaps. And as a way to kind of pass the baton to Carrie here also, the work in this space is always changing, and we're talking actually less about health equity now, as we're talking more about diversity, equity, and inclusion. And we talk about that both as a healthcare organization and then also as an employer. And so we've expanded it beyond just health equity. And the other thing is, there's a lot of talk in recent months about becoming anti-racist or becoming an anti-racist organization. And that is also a change that we have adopted within within group health as well. And anti-racism, just briefly, says it's not enough to disagree with racism or say that you're against racism or to denounce it. You have to make very, very meaningful changes to fight racism. Otherwise, all the words in the world don't really mean much if you're not making changes. And last thing that I'll leave with you is, I love this quote, that anti-racist educators understand that all forms of oppression are connected, that it is not possible to care about racism and disregard the violence in sexism, classism, homophobia, and more. The hearts of anti-racist advocates push us to be concerned for all violations of human rights. And so with that, I will pass off to Carrie, and I'll look forward to our Q&A session at the end.
Great. Thank you, Dr. Huth. And I do realize that the slides for the presentation are a little delayed, so I will just wait until they get to DEI work at GHC as an employer. So I appreciate, my name is Carrie O'Dell, good afternoon, Chief Human Resources Officer at GHC, and I really appreciate the opportunity to showcase some of our past work we've done in this realm of diversity, equity, and inclusion, and what we're planning to do as we move forward. A lot of this work that Mark has mentioned really overlaps and intertwines with our membership and our patient care and our employees. And that is because we employ the staff that gives this experience to our members. So a lot of what I'm about to go over overlaps with what Dr. Huth had mentioned, as these all intertwine so closely. First of all, GHC has a history of diversity, equity, and inclusion efforts, and especially in the employee groups and community partnerships. Looking back at our journey, many things we've already done throughout the years, but most specifically, it was the formation of our inclusion change team. And we created that in 2017 with the help of the HR department and the community care and diversity equity manager. And we recruited all staff, put out an application and interview process, and now we have the formation of a multiracial intercultural leadership advisory council. And they have that dedicated workspace formally at GHC to move this work along. As Dr. Huth had mentioned, a lot of their projects centered around those we believe statements that he went over earlier, that this group was able to work on with employees throughout the organization and get their perspectives on healthcare. This group also works closely with a couple other employee resource groups at GHC, specifically the LGBTQ group of employees who helped with those all gender restroom signs and getting that underway. And this group meets monthly and they are able to host these dialogues in a safe space. Another addition is we realize the work needs a dedicated full-time position, right? We have diversity, equity, and inclusion leadership position now posted as a full-time position, as the work does need that dedicated space. And it's very important to realize that and put the money and the budget where that work can be put forward. In addition, the Deep Diversity Institute immersion training is also was reflected within the employees as well. The senior leadership team and the board went through part of that and were able to acknowledge their biases through that very intense training and bring it back to their day-to-day interactions at GHC. So I think it's really important to note that most of what I'm going over here, all of the leadership is involved in, all of the board is involved in. It really is starting at the top and getting that, buy-in, what is really important for employers, and able to disseminate that down and have the staff respect that. And in addition, finally, I'll touch on here, learning and development curriculum is very important as well. Obviously, with this work, there's a lot of training and immersion classes that we create and provide the tools for staff to go through as self-study modules if they wish on their own time. We also provide opportunities for leadership development classes for all of our employees. This is for management staff in our Leadership Keys group and Rising Leaders, which is our frontline staff. And that helps to develop their career path with continual learning and engagement. And recruitment is always important with diversity, equity, and inclusion work. We want to make sure we're putting all of our job ads out there in diverse publications. We want to make sure this diversity, equity, and inclusion questions are in all interview. Every person who comes through gets asked a certain set of questions to realize that, this is important work at GHC, and we will be focused on this right from the candidate experience. Next slide, please. And as I had mentioned, this slide just shows some of those training classes that we have offered at GHC right now that staff can go through the learning process on their own with it, which they are comfortable with. Some of those classes are in their learning management system, so they can log in and take them. We used to have them in person, and obviously we can't do that anymore. So we're hosting more the self-study training modules. Next slide. Our strategic plan. This is probably, one of the most important things to reiterate through your diversity, equity, and inclusion journey, and through our journey as well, is putting this in the strategic plan. It's part of our driving strategies and our tactics. Continue to invest in and expand health equity and diversity in GHC staff, as well as health equity training. So that is right in there, plain as day for staff to see. And there's goals tied along those, so they have to be measured. It's part of our work as an organization, and therefore we have to measure the success of this work. And that is in the forefront of our day-to-day operations. So that's really important, and I want to reiterate again, to have that as part of our driving strategy, and have all of the leadership team, as well as the goals that go up along with that, as part of our journey through diversity, equity, and inclusion, and it's deeply focused on at the highest level. Next slide. And then we had the events of earlier this summer involving George Floyd, which is not something we can ignore, and not something we could ignore in our as an employer. Employees were hurting. Employees wanted acknowledgement from their employer that they were committed to the work. Our board of directors put out a message directly to all staff acknowledging the current events and offering continual commitment to the work. The inclusion change team that I spoke of before and senior leadership put out a joint message along the same forefront, as well as our board offered a grant from their governance budget to make a donation to 4 organizations working to improve the equity and quality of Black lives in Madison. And then Dr. Huth agreed to match that amount from operations. So we wanted to put some significant sustainable things behind the actions that we were doing during this difficult time. Next slide. And during the events earlier from this summer, we heard directly from employees on their experiences and their hurt, and that came up through our inclusion change team. They were able to hear from staff in a safe space what their feelings were throughout that time, and we were able to meet with them and hear those first words experiences. And some of those things are on this slide. Direct quotes: people fail to acknowledge how Brown and Black employees feel. My own discomfort is invisible in the workplace. I am forced to carry the weight of this burden on my own in my workplace. It is too much. So those were very sobering to hear, but we acknowledged them. And that was all we could do in that moment to show them that we were reunited and we heard them. But we took that a step further. Next slide. We had conversations with the inclusion change team during this difficult time, and the senior leadership team and the health equity committee. We chose to meet directly with them to learn more in a safe space and provide that outlook. We acknowledge that we've done many things, but there's more to be done, more work to be done ahead, and we will take the time and be patient. We had some real talk and authentic conversations, which are very important when working in this realm. And once again, we just acknowledge that we don't have all the answers, but we're committed to listening, learning, and taking actions. In that moment, we had conversations with managers about ways to support Black and Brown employees during the time of unrest. But what are we going to do next? What can we do tomorrow? That question is constantly on our mind now, and a lot of HR practitioners and senior leaders during this time. Next slide. So we acknowledge, we do not have that FTE and specialty in our house to dive further in this work. And we decided we would partner with a third-party certified diversity, equity, and inclusion specialist to perform an audit. In working on this audit to understand the current environment and opportunities, and hope to develop a strong foundation for cultural change. So some of the things that we are currently working on with this third-party specialist is a survey going out to all staff with questions related to what they are experiencing in the workplace. This actually just literally opened up last week and is currently open. So we're really, anticipating those results and excited to hear, ways we can improve and what staff are going through firsthand. We also will be doing interviews with key stakeholders. Our auditor will be doing that, and focus groups throughout the organization to hear exactly what the frontline staff is going through in their experiences. This will include all levels of the organization, including our board of directors, which is very important in this process. And then we hope to have future focus areas that, will come out of this audit, and some of them being, we know we aren't perfect in a lot of our policies and procedures, and no one, can be. There's always room for this opportunity and this different lens to look at things that we are doing now. So we're going to look at our recruiting practices and hiring practices, and dedicate more time for training, dedicate that time for staff to have to do this training opportunities in the future. Next slide. And also with this comes our partnerships with community partners that are very important part of our structure, and how we operate at GHC. We work currently with Urban League of the Greater Madison area, and we'll provide training and employment opportunities for Black and Brown individuals who are interested in a career in insurance and healthcare, where maybe they weren't able to get that firsthand experience before. We partnered directly with the Urban League to bring the pipeline into GHC. We also do a mentorship program for development of leaders within our organization. And then some other learning opportunities that we continuously work with are YWCA of Dane County. They provide formal training on the diversity, equity, and inclusion lens, and come in-house. Well, they used to be able to when we had face-to-face trainings, but now virtually we do those trainings. Just last week, there was a racial justice summit that we sponsored a group of employees to attend so that they could, have that time outside of their normal job to get this information and have that safe space. There's a Wisconsin Leadership Summit and other regional economic diversity summits that we sponsor, as it's really important in healthcare and especially in this realm to work with our community partners to develop the pipeline for future employee and training opportunities. Next slide. So in conclusion, there really is no conclusion to diversity, equity, and inclusion work. And we realize just, everybody has a role in this process, and nobody does the work alone. We're listening from every level. We realize this is continual work, and it'll take some small steps, but small consistent steps. And we know it's complicated. We don't have all the answers, but we're committed to learning and taking an action and going with it from here. So I look forward to the question and answer panel coming up. Otherwise, that's all I have for my portion of the presentation.
Thank you, both Mark and Carrie. I think you can tell that we have had a significant wake-up moment when we thought we were providing, and we do provide excellent healthcare, but not for everyone. And I'm very proud to be on the board of this organization that has embraced doing the work for diversity, equity, and inclusion, and that there's a strong relationship between our board and our leadership and our members to support this kind of work. I'm also proud that we're doing it during a time when for healthcare it's been very challenging to deal with the COVID pandemic, but we haven't lost sight in any way that we need to keep our focus on doing our anti-racist group work. Finally, I think that it's admirable of the organization, and this is from the board down, that we are really committed to becoming a model cooperative that is an anti-racist organization. We want to be a model in our community, in the country, and particularly among cooperative organizations throughout the country. So to summarize what we've done and kind of help you understand how to go about this work or think about it, I wanted to share with you a framework from the Institute for Healthcare Improvement. I think you could go through these slides and figure out what's next for you to just insert the name of your industry instead of healthcare in all of this, and you would have a good guide for the steps to take. So what you've heard is that we've done many of these things and we're still doing them, but we've made health equity a strategic priority. We've developed a structure and processes to support our health equity work throughout the organization. We've deployed specific strategies to address the multiple determinants of health and how healthcare organizations can have a direct impact. We're working to decrease institutional racism within the organization, and even just to identify where it exists. And we definitely have had long-term partnerships with community organizations to improve healthcare in Dane County. I hope we've been helpful in sharing this information for you, and we are all looking forward to your questions. So I'll turn the microphone over to Dr. Huth.
Great, thank you, Anne. And thanks everybody. So I will be happy to answer whatever questions I can, and Carrie and Anne as well. This is our first presentation at the Impact Conference, so I'm not quite sure how we will get the questions. Perhaps our host can help us with that.
While we're waiting, perhaps, Mark, you could answer some of the questions that you've received as you've talked about this work with your colleagues or in community groups.
Yes, well, a few things we've talked about already. The fact is that disparities in healthcare and discrimination in healthcare is rampant, and it is everywhere. There's also good news there in that there are a lot of opportunities and a lot of partnerships that can have a very significant impact. One of the places that we've been able to make some inroads is by casting a wider net when we are filling positions within the organization and trying to attract more diverse colleagues and to our organization at all levels of our organization. And that has been something that we still have a lot of work yet to do, but we have had some success. Specifically, for example, attracting people of color to our provider group and to our nursing staff and reception group, so the more outward facing part of the organization. And that's been something that we have made some real inroads on. However, it's also true that we don't often get as many diverse candidates for open positions as we would like. Madison is a very white city, and I think that that tends to affect the way that we're able to recruit. So one of the things we've done, as Carrie talked about, is work directly with organizations like the Urban League here in Madison to identify people in school or high school or who are out of school that have a desire to work in healthcare but need training. And so we participate in the training to get them the skills that they need to apply for positions. And then we do whatever we can to find work within our organization for them or at other organizations as well. But we've had many people go through this training and gain the experience and the knowledge that they need to move into an insurance career or a medical career. And so we're actually looking to expand that and are even talking with the Urban League about helping with scholarships should somebody want to go to college to get a nursing degree or a certified medical technologist degree so that they can work in healthcare. And so much more to come on that, but that has been something that has worked very well for us to date.
Mark, there is a chat, so I will ask the questions from the chat. Have you received any pushback in the DEI process? I'm thinking in light of prohibitions by the current president against DEI training for federal government employees and contractors. So I guess we both can answer that. Go ahead, Mark.
Yeah, the answer is yes. I have to acknowledge that this is uncomfortable work at times, And in fact, it's been said many times that if you're talking about racism and you're not uncomfortable, you're not talking about it the right way. It's hard to get involved in this conversation. It's hard to talk about these things without people feeling uncomfortable. And so the balance becomes, how do you create enough discomfort that people feel motivated to change and to be partners with you in change, without pushing so much that you start creating enemies or people that are going to fight you. And we have over 800 employees, and I would share that for the previous 2 years at the all-staff meeting, I got really nice comments about my hour-long presentation. And then the year that I talked about health equity and about implicit bias, it was very mixed. And there were quite a few comments about how they felt it was really inappropriate to talk about racism, and that we're not a racist organization, that we're really good people, and racism does not exist at Group Health. And so, those of us leading this work and working in this work understand that we just have to meet people where they are. We still have to continue to work on it. There may be some folks who decide that this is not the kind of organization they want to be part of. And, we need to be prepared for that as well. And at the same point, we also have employees who are saying to us, why is this taking so long? We should be doing more, and we should be changing quicker. And so, there has been a lot of pushback from some employees, but I kind of take that to heart, because it means we're talking about the right things, and it means that we are shining a light on the structural racism and discrimination that exists here and exists everywhere. And I echo Ann's comments also that, really our call is, we want to be a model organization. We want to be someone leading this charge and really improving the quality of organization that we are, both for our employees and for our patients.
Yes, good answer, Mark. And I, ditto to all of that. And I will say, working in human resources, that yes, most definitely there is the pushback that Mark had mentioned. And, staff will come to us not happy that we're working fast enough, or come to us, kind of just taking everything to heart, which, totally understand, but, want us to work faster. So it is a juggling act in that sense. And we do need to have that approach of, coming down to everyone's level and being able to collaborate with them rather than just push this work. So I think that's a really good way to explain it, how you said, Mark. Looks like there's one other question here. Is it possible to share the diversity, equity, and inclusion questions that you ask while interviewing? We should be able to share that. I'm not sure if there is. I can reach out to our moderator on if there's some follow-up capacity on how we can send those in the future.
I wanted to comment just for a minute on the previous question.
Yeah.
Mark mentioned, or Carrie mentioned, that the board had sent a letter to our staff after the Black Lives Matter protests. And the letter was very strongly written in terms of how we feel and what we intended to do. And the entire board was given the opportunity to sign the letter with no expectation that that they had to. It was definitely made clear to them that it was a choice. And as the board chair, I really didn't know how the board was going to respond because it was a strong letter. And I'm very happy to say that every board member signed that letter, and it went out to every staff member so that they know that from the board through the organization that we're committed to this work and and committed to going through the hard parts of it, which definitely exist.
That's a great point, Anne. And something else that comes to mind that I think has been helpful is those of us in leadership, when we're talking about discrimination and talking about the gap in health equity, I think we focus on our own experiences and our own need to learn and to improve, rather than talk about how bad the rest of the organization is or how other people may be approaching it. And I might use the example that in the health equity presentation that I did for all staff, I shared a patient experience that I had, and I'll share it very quickly with you here. Within a couple of months of each other, I saw two individuals. One was a white business owner, construction owner, who came in and said, he had hurt his back and just needed some pain medication, opioid pain medication. And so I gave him, a small amount to get him through. And he came back for a couple more refills, but seemed to be improving. Very shortly after that, I had a Black individual in his 20s come in, and he had a really horrific knee injury in high school football that he had gotten through, but he was a referee and he loved reffing basketball and football games. And he said some nights after he's done a lot of running up and down the field, his knee pain was so significant that he just couldn't sleep. And could he please get some strong pain medication to help him sleep? And in that scenario, I also gave a small amount of pain medication, but my discussion with the patient was much more detailed about the risk of the medication, about the potential downfalls, and the fact that I was not going to give a lot of this medication because of safety issues. Fast forward a couple of months later, and the white individual came in and sat down in my exam room and said, "I've been lying to you all along. I'm addicted to heroin. And when I can't get heroin on the street, I use the Vicodin to just get me through, and I need help." And the Black individual always used the medication, to the best of my knowledge, exactly as it was prescribed, and was very, very responsible. And the two things about that I really wanted to share with my colleagues were, number one, implicit bias was an unknown behind the scenes commentary in my head that led me to assume one individual was more likely to abuse a medication than the other. And if I truly wanted to be a champion for health equity, I need to understand where that comment is, or where that conversation is in my head, and stop it and take a step back and say, what is the most equitable thing to do? And then the other thing about it is, if I am giving a talk on the dangers of a medication to one patient, I should be doing it for all. And it was substandard care for me to not have that conversation with this other patient. And so in an attempt to be vulnerable and in an attempt to be authentic about health equity, I think it helped for people to hear my own learning and a place where I came face to face with my own implicit bias and my own gap in health equity.
Thank you for that, Mark. I think you can see that we have a leader in our organization that's helping all of us understand how we need to think ourselves and what we need to be conscious of, which has, I think, helped everyone in the organization to see that from our CEO. Are there any other questions, Carrie?
No, I do not see any other questions at the moment.
We'll wait a couple minutes, and then I think if there are no more questions, we'll figure out what to do next. So, are you seeing any? No? Well, I know it's early, but if you're participating in all these workshops, I'm sure that you're having a little computer fatigue because it's a very, very busy conference. And so we're going to give you a inclusive gift to everybody to have a few extra moments to take a break and also think a little about what you've been hearing and what you will hear on this spectacularly organized conference. Thank you both to Mark and Carrie for your willingness to be open about our programs here at Group Health. And if any of you have any questions, we're all, I believe, listed or through the participants book, and all three of us would be very happy to answer any questions that you'd like to send us. And on that note, thank you to the conference, thank you to our webinar host, and thank you to Mark and Carrie, and please stay safe and stay healthy. Goodbye.
Thank you, everyone.